Good morning, Dr. Feliz.
Good morning.
Could you begin by explaining to us, in general terms, exactly what is complex regional pain syndrome or reflex sympathetic dystrophy?
Complex regional pain syndrome or reflex sympathetic dystrophy, in order to really understand it, you have to understand how does the body respond to trauma. Once you understand that part, then understanding complex regional pain becomes easier.
So why don't we start there?
Sure. Whenever the human body is exposed to trauma, to an injury, you sprain an ankle, you get shot, you get cut, the body responds by the immune system sending what we call the inflammatory mediators into the site of the injury. And some of these mediators are substances called like prostaglandins, kinins, bradykinins, histamine, potassium, calcium. All of those are the substances that go to the site of the injury to alert the body that something happened. When that occurs there, that's the initial inflammation. Most patients, most human beings, that reaction, that acute early reaction, lasts between 2-3 weeks, after which the body begins to pull all of those mediators, all of those substances out of the way. It brings it back to the blood, to the circulation, to take it back to circulate around the body, to monitor the next trauma. And usually after 2 or 3 weeks, the body begins to heal. So that's the normal healing process. What happens in patients with complex regional pain, we now believe, those patients who develop complex regional pain tend to maintain the inflammation longer than normal. So that now we call it there is an ultra-local inflammatory reaction that persists at the site of the injury longer than normal. And in fact, you can look at the tissue that became traumatized or injured, and from the outside, the tissue looks normal. But yet, there is still something going on there, which we believe is actually caused by and maintained by the body immune system. When that happens, the whole thing gets wound up. The first thing that occurs is that, and that we know, is that in those patients that develop complex regional pain syndrome, most always, and I'm still trying to find one that has not had a nerve injury there. So we believe that what tends to maintain this inflammatory reaction longer than normal is that there has been a nerve injury, which is why usually complex regional pain is associated with neuropathic pain or nerve injury. Whenever in the body you traumatize a peripheral nerve, or you cut it, you lancinate it, you compress it, the body tends to form tissues called neuromas, which are it's almost like an ingrown hair. It's a little bundle of nerve tissue that is extremely sensitive to touch. It depolarizes quickly, and because it depolarizes with minimal sensation, it tends to send messages to the brain very quickly. Now, up to this point, the sympathetic system is not even involved in the pain. And in general, our sympathetic nervous system has nothing to do with bringing pain to the body, to the brain. When there is trauma and you injure a peripheral nerve, the sympathetic nervous system that's coming down from your brain in front of your spinal cord, it tends to go to the site of the injury, and it tends to form a basket connection. It tends to attach to the site of the injury, and in particular to the neuroma. So now you have a connection between a neuroma that's very painful, which is a somatic nerve, and the sympathetic nervous system. So what happens? If you stimulate the neuroma, which is a somatic nerve, the patient feels pain. But now because you have a connection between the sympathetic and the neuroma, if you stimulate the sympathetic, the patient also feels pain. That's the first connection that occurred. The nerve that got injured, there is a connection right next to the spinal cord called the dorsal root ganglion. It's like the first body of the nerve. The sympathetic system from your spinal cord level also attaches to the dorsal root ganglion. So now you have two connections, one at the site of the injury and one at the spinal cord level, so that if you stimulate the sympathetic, you're stimulating the nerve, and if you stimulate the nerve, you're also stimulating the sympathetic. That connection occurs. And lastly, we know that patients that have developed complex regional pain syndrome, and we now believe that they have this persistent chronic inflammation at the site of the injury. In this case, we took the wrist or the hand. This continuous bombardment of messages to the brain does something to the brain. It's what we call neuroplasticity, which in changing it is just adaptation of the brain to pain. And what occurs whenever you send continuous message to our brain, it's almost like if you're trying to memorize something. The brain remembers. If you continuously send pain message to your brain, the neurons in your brain change how they perceive pain. And the way that's done pathophysiologically is that the messages, there is a substance that goes to your brain called glutamate and substance P that stimulates a receptor in your brain called the NMDA receptor. When that occurs, a bunch of inside reactions occur, which are clearly beyond this explanation, that forces the neuron itself, the neurons, the cell body that's connected to of the nerve that got injured, to suddenly begin to stimulate itself. It begins to produce something called nitric oxide. It begins to produce something called prostaglandin that comes out of the body, goes back to the site of the injury, and it stimulates itself again. That's called wind-up. That's called neuroplasticity. This combination of this wind-up, the connection at the periphery between the sympathetic and the somatic nerve that got injured, the connection at the spinal cord, this entire connection is what complex regional pain syndrome is, which is when we were in medical school, we thought that it was a simple nerve injury. Now we understand that it's more complex. Now, if you understand it at this level, you immediately begin to realize why is it so difficult to treat complex regional pain syndrome, because we're dealing with a problem at the brain level, we are dealing with a problem at the spinal cord level, and we are dealing with a problem at the periphery.